Now, can you thank the for the channels of by on the topic. It's an area that causes a lot of distress to patients, and these disorders are extremely common. I used to speak on hemorrhoids, in a region beauties, and also about steroid failure. Now, one thing I would like to very much stress the importance of examining this region and this digital rectal examination. The skill that every doctor should have is not something that should be done only by surgeons. In fact, there is a whole thing you don't put your finger in, you put your foot in, right? And many cases of, for example, things like rectal cancers, right, can be diagnosed by a simple digital rectal examination. But of course, it is also important to adopt the correct technique and not to hurt the patient. Right. So, moving on to one of the very common conditions, renal fissures. The word fissure basically means a crack. So, it is a split in the skin of the lower anal canal or a crack in the enoderm. It's a very painful condition and it is associated with spasm of the internal anal sphincter. And in fact, that's one reason why fissures don't like other wounds. So this spasm tends to increase. It's more common in children and young adults, but it can occur almost at any age. It generally occurs in the areas of the anal canal which are least supported. That is the posterior midline, and also the anterior midline, particularly fourth part of it. There is strong association of constipation, but if there are multiple fissures in other areas, one has to think of inflammatory bowel disease like Crohn's disease. So, when it comes to management, our aim is to reduce the sphincter spasm, to reduce the pain, and to promote healing. So, there are various simple measures that can be used. Now, one thing is warm sitz baths, where a person would sit in a warm bath water for about 50 minutes twice a day. And that generally helps to relax perianal muscles, also increase the patient comfort. So, ensure that the patient has a normal stool. And therefore, now there is a lot of emphasis on the fiber, right? And that is true. We have a fiber of the food. But there is adequate breathing rate, the patients are going to be constipated even if they eat the donut. So that is very the other aspect is the tips. You get different things. You get stool softeners, bulk formers, but essentially now most of the proprietary preparations are combinations of. And then of course you can use the local anesthetic gel. Right? So these are the sort of simplest measures that can be used in this patient. But usually this alone is not enough. So we have these chemical treatments aimed at relaxing the internal anal sphincter. We have glyceride cyanitrate and diltiazem creams. Both creams are equally effective, but leaky tends to cause headaches, just like the therefore, diltiazem cream is required. Now, if these patients are not responding to this medical therapy, Or if they are getting current fissure, then one has to resort to surgical measures. Now, in the days gone by, people used to do what is called in the inner. It was first tried by a famous surgeon, almost 100 years ago. The Lord, they are said you can fix the anus, we operate to heal the features. They need it's not a fair proportion of these patients, but incontinent in later life, right? So therefore, it is considered unacceptable, and today we do not do this for anal sex. Another option is Botox injection, where you can inject Botox to the four quadrants and that way paralyze the internal anal sphincter. It is an effective form of treatment, but of course can result recurrent. So one definitive form of treatment is lateral sphincterotomy, where the internal anal sphincter is divided right up to the dentate line, and you get healing in almost 90% of patients after the procedure. There can be mild incontinence initially in about 30% of patients, but it becomes significant only in less than 1% of patients. Of course, you can have other little problems like hematoma formation, abscess formation, and so on. So it is a perfectly acceptable method of treatment. Moving on to hemorrhoids, there are various degrees of hemorrhoids that are described. Initially, the hemorrhoids just collapse into the anal canal. It is called first degree. Then it collapses outside the anal canal, but goes in spontaneously. After some time, it comes out and then doesn't go in. It has to be pushed in. In fact, one patient who was a mechanic came and told me, then auto ඇතුළට යන්නේ. And then of course, you have the complicated hemorrhoids which cannot even be pushed in. So initially, now when we were medical students, we were taught that these were varicosities of the superior XL vein. But then people observed that the blood that these patients bleed is bright red blood, and therefore it is not venous blood. So now it is believed that there are these three hemorrhoidal cushions which are usually situated in these three positions, that is the right anterior, right posterior, and the left lateral. Also called the 3-7-11 positions if you keep the patient in the lithotomy position. And these tend to get compressed by the feces, and particularly in constipated patients, these during straining, these cushions tend to get pushed down. And they have a rich blood supply directly from the rectal arteries. There are also AV shunts inside these hemorrhoidal cushions. So what about treatment? Now, one important thing to remember that in older patients, these hemorrhoids may be secondary to some other lesion, and what we are most worried about is a rectal cancer. Right? So, therefore, patients who are over the age of about 40 years and also those who have alarm symptoms like tenesmus, where the patient always has a persistent desire to defecate, or patients who have a sense of incomplete evacuation, or people who are constipated, all these people require either a flexible sigmoidoscopy or a colonoscopy to exclude malignancy. That is very, very important. And it has been shown that about 50% of people over the age of 50 years have got hemorrhoids, right? At least in the West. So therefore, treatment is only for symptomatic patients, because all these treatments also have some problems associated with them. Now, the medical treatment consists of, again, high fiber diet, fluid intake, laxatives. Six parts, again, make it comfortable for the patient. And then, of course, you have these drugs called flavonoids. These are basically plant extracts, and their use is somewhat controversial because some people feel that they don't work, but they are actually sometimes quite useful in these patients. They reduce bleeding, reduce congestion, right, and improve patient comfort. Then you have the different outpatient procedures like sclerotherapy, banding, radiofrequency ablation, and then you have the operating theatre procedures like laser, stapling, or hemorrhoidectomy. Now, out of all these procedures for advanced hemorrhoids, the uh, uh, the thing that works best is hemorrhoidectomy. So that is why we uh, still resort to this age-old operation, but it is significant. It can sometimes be associated with significant pain. The problem with laser and stapling and all these other methods, right? There is also Doppler ligation of hemorrhoids. You can use Doppler guided ligation of hemorrhoidal vessels. In all these other forms of treatment, there is a significant recurrence rate. That is a problem. But otherwise, most of them are relatively painless. So this is a picture of a prolapsed hemorrhoid, right? One that doesn't go in auto. And these patients sometimes present as emergencies requiring admission. The problem with these prolapsed hemorrhoids is that it can lead to infection, infarction, gangrene, and even fatal pyoemia, which can be a life-threatening complication. They are initially managed conservatively, followed by surgery, or you can resort to emergency hemorrhoidectomy based on the preference of the surgeon and the patient. And again, conservative management would include, once the initial period is over, conservative management would include fixed baths, pain relief, and antibiotics. Moving on to abscesses, there are a lot of loose spaces in relation to the anal canal. So that's the rectum and that's the anal canal. And infections can get into any of these spaces and cause abscesses. So you can have a perianal abscess, right, just under the skin there. Then you can have ischiorectal abscesses, which can extend quite deep because without areolar tissue. I've seen patients who had almost a liter of pus inside those perianal abscesses, and some ischiorectal abscesses. Sometimes they can even communicate with the other side posterior to the anal canal. You can also have abscesses between the internal sphincter and the external sphincter. Those are intersphincteric abscesses. Right? And then, of course, you can have abscesses even above the fibula levator and in the pelvis. So those are extremely rare. So this is usually a painful emergency requiring admission. Here, unlike in fissures where you get pain during and after defecation, these patients have continuous pain, and the pain even keeps them awake at night. And it's a throbbing kind of pain, and you may see a tender red swelling in the perianal skin in fair people like squanting, right? But in most of us, right, you will not see that reddish hue. And you can also have local tenderness, and there will also be local tenderness. And on digital rectal examination, there would be a soft fluctuant swelling. Now, it's important to remember that these abscesses could be due to underlying fistulae. They could be due to underlying fistulae. So, it's important to warn the patient, because at this stage, all we do is drain the abscess, right? And look for a fistula, right? But later on, patients can get recurrent abscesses if it is due to anal fistula. So, in abscesses, actually, there is no place for conservative management once pus is formed. Very initial stage, just day or two, when the inflammation has just started, might be able to get away with antibiotics, right? But once pus is formed, it has to be drained. And even some of these abscesses may rupture or leak, right? But that drainage is insufficient. So they need formal drainage. And the cavity has to be left open after drainage. And actually, after drainage, abscesses as well as abscesses in other parts of the body actually don't require antibiotics unless there is surrounding cellulitis in the area. Hence, in pus for culture, but many of these infections are anaerobic. So, therefore, unless you are doing anaerobic cultures as well, it doesn't really make sense to send pus for culture. Of course, there are some people who culture these organisms, culture the organisms, that is including anaerobic culture, and then they conclude that if there are enteric organisms, that means there's a connection to the inside. So, in other words, there is a history. But within it, there is not much value in doing pus cultures in these patients. These people need daily dressings because, unlike abscesses in other areas, these get soiled. This area gets soiled every time when the patient goes to the toilet. But it's very important to dress these wounds very light. They should not be packed tight because very often they will be dressed by the primary or under the supervision of the primary care physician. It's very important not to pack them tight. Our former professor used to say the only thing you should pack tight is your suitcase, right? So, therefore, light dressings are much better because it allows the exudate, the pus, to drain. Of course, MRI and endoanal ultrasound may be used to make it complicated and that is very useful. Now, if you look at fistulae, occur due to infection of an anal gland, and often it presents as a perianal abscess. So, if you think about it, what really happens is that bacteria one of these anal glands and it causes an infection. Then it ruptures to the inside as well as to the outside, and then you have a communication between the skin and the anal canal. And that is called a fistula. Fistula, by definition, is an abnormal communication between two epithelial surfaces. Now, so therefore, an abscess would have, fistula would have an internal opening, a tract, and an external opening. And out of these perianal conditions, I must say it is one of the more difficult conditions to treat. And you will come across patients who have either had staged procedures, right, where you do it, don't do it as one operation, you do it as staged procedures. That is, initially you use a draining sit-on, then later you do another procedure and so on. Or you may come across patients who have had multiple procedures due to recurrence. So, this is a sort of a worldwide phenomenon because no treatment is 100% effective for the management of fistula. And that is something that is also important to understand and important to explain to the patient. Otherwise, they feel that, someone has done something wrong. Not the case. So, this shows you the external opening. And you get different types of fistula. Internal below the dentate line or above the dentate line, but these are the different types. How you can divide them related to the thing. Amazing number of students who spell as anal sphincter. Okay, so coming to the treatment. Treatment is always surgical, but there is no treatment for anal fistula, right? Some and essentially you get three forms of treatment. You can do a fistulotomy, that's where you lay open the fistula and then cure it or scoop out the base, or you can remove that tract, which is called a fistulectomy, but the results of the two procedures are the same. Then you have the sit-on. They are, it's a draining seton. So you the suture through the external opening, through the crack, through the internal opening, bring it out, and you can tie it loosely. That is called a draining seton. Now, basically, when you're draining seton, you're not really healing the fistula. You're dealing so that parts of this won't get blocked and give rise to perianal abscesses. People also use sucking seton, that it can be going across the anal sphincter. Right? I told you there are several types of fistulae that go to the sphincter. What happens if you lay it open, the patient might develop incontinence. So therefore, you use a cutting seton, that is, you use a suture like a nylon, tightly, right? And then keep retightening so that it cuts slowly. So when it cuts slowly, you get fibrosis and the patient doesn't get incontinent. So that is another method of treatment. And these setons are also used not only by us, but also by the Ayurvedic alternative medicine. Then you have various sphincter preserving procedures. These are more or less definitive procedures. There is a glue that can be injected to the external opening, but it doesn't work very well. Your patients develop recurrences, but of course, it's a totally painless treatment for the fistula. Then there was another thing which was called, not putting down here, which is called the anal fistula plug. Right? It was made out of a porcine material, but again, the results were extremely poor, and worldwide it has been given up. So then you have laser treatment, where you can use a laser fiber to burn the granulation tissue in the crack. There is also a thing called VAF, video assisted fistula surgery. So now you know that there are different endoscopes, right, which we pass through different orifices. There is also this scope, very fine scope, which you can pass through a fistula, right? So you can, from the external opening, and go through the track, reach the internal opening, and then you have a diagonal-based method to burn the track. So that is called VAF. There is also an operation which is called lift, which is called the ligation. This is the ligation of eccentric fistula tract. Where you can ligate the fistula tract between the internal and external sphincters. So all these have varying degrees of success, but as I said, nothing works 100% in all patients. Moving on to this other common condition, which you may not, which I'm sure you would have come across, pruritus ani. It affects 1 to 5% of the population. Quite common. Males more than females, generally in the 4th to 6th decades. In Sri Lanka, this is often attributed to worms, which is called the Kiripanugaya. Most people consider that this is due to pinworms or threadworms, Enterobius vermicularis, which actually it can be, right, in some cases, and there is no harm in giving these patients a course of worm treatment. Believe it or not, pruritus has over 100 causes, and common causes include perineal fecal contamination. That is, some patients have incontinence, others are unaware that they have a little incontinence. Sometimes with passage of gas, right, you get a little bit of liquid feces coming out and soiling that area, and that gives rise to pruritus. That's one of the commonest things. Then you can have infections like candida or the threadworms. Then you get contact dermatitis, because people use deodorants, creams, then perfumes, wet wipes. In fact, our teacher, Professor Dayasiri Fernando, told us that God hid the anus between the buttocks to prevent people putting lipstick around it. So these are various things that people use, and then they develop pruritus. Then moving more on to Suranjit's area, various food types, right? Various foods, right, cause allergies, specifically in that region. Caffeinated drinks, alcohol, peanuts, all these things, right, have been implicated. Then hemorrhoids, occasionally cancers, fistulae. Then clothing. some people are sort of allergic to nylon and various undergarments. And then, of course, you have the systemic diseases like diabetes mellitus, chronic liver cell disease, chronic renal failure, lymphomas, pruritus. So in these patients, it's very important to take a very detailed history. And when you do the digital rectal examination, you assess the sphincter tone. So there are two sphincters. You have the internal sphincter, and that determines the resting tone. So as you pass the finger, you can feel the tone of the internal sphincter. Then you ask the patient to squeeze, and you have to explain, because some people otherwise with their hand they try to squeeze your finger, right? That has happened. That has happened to me, right? So you have to tell the patient with your own effort, try to squeeze, and that way you test the external sphincter, right? So that is so that you're assessing these patients, important to check the sphincter tone. And then, of course, treatment is treatment of the cause. You can't find a cause. Best thing is to give them a course of exercises, because now I said earlier that sometimes this big one may not be overt, right? And the other thing is somehow they derive some benefit in it, because this takes their mind off the writers. You see, they keep on tightening and relaxing renal muscle. So sometimes it is their mind off the problems. But of course, if it is due to allergies, all we have to do to write the allergic aspect of all. So, so with that, I come to the end of my talk. Thank you very much. Thank you.